Thank you all for joining us for this webinar on optimizing lactation care for diverse populations. I'm so glad that you have joined us today. My name is Dr. Diane Spatz. I am a professor at the University of Pennsylvania School of Nursing, as well as a nurse scientist for the lactation program at Children's Hospital of Philadelphia. As of April of this year, I also was elected to the executive committee of the International Society for Researchers in Human Milk. So I'm first going to share with you just a little bit of background. I went to the University of Pennsylvania for my BSN, MSN, and PhD. When I was an undergraduate at the University of Pennsylvania, I did not learn anything about human milk or breastfeeding in my program of study. I also did not see any breastfeeding mothers or families when I had my clinical experience, because at that time, breastfeeding rates in the United States were quite low. So since my graduation from my baccalaureate degree, I have really focused on strategic methods to improve nurses' knowledge about human milk and breastfeeding. I went straight through for a bachelor's, master's, and PhD. And in 1995, I received my PhD, was appointed to the faculty at the University of Pennsylvania, and I had my first grant funded by the National Institutes of Health. This is important background to understand, because at that time, no one was really paying attention to human milk and breastfeeding, in particular for vulnerable infants. And in this research study, we demonstrated that if women who come from all backgrounds have appropriate evidence-based human milk and breastfeeding guidance from advanced practice nurses, human milk and breastfeeding outcomes will be improved. So with that grant starting in 1995 and my faculty appointment in 1995, I initiated the first ever undergraduate course on human milk and lactation for nursing students. And in this course, they have 28 hours of lecture, as well as 14 hours of clinical experience. This course has been noted by the Centers for Disease Control and Prevention to be a best practice. I share this background with you because in the two topics I will talk about today, homeless families as well as adolescent families, students who take my course at the University of Pennsylvania work with both of these populations. One of the options for the course is to write a manuscript. One is to work one-on-one with a breastfeeding family. And the third is to conduct what is called an advocacy project, where you work with an identified community to improve human milk and breastfeeding. And through this course, countless number of my students have done their advocacy projects to improve breastfeeding, not only in Philadelphia, but all across the United States. So I was also, following the NIH grant, recruited to the Children's Hospital of Philadelphia. And at that time is when I developed my 10-step model for human milk and breastfeeding in vulnerable infants. And this is very critical, because when we have mothers who are separated from their infants, the principles of the baby-friendly hospital initiative really don't meet the needs of critically ill babies. So at Children's Hospital of Philadelphia, since opening of our special delivery unit in 2008, we have close to 100% pumping initiation rate. We ensure that every family we meet has the opportunity to make an informed feeding decision. And when infants are admitted within 7 days to Children's Hospital of Philadelphia or born in our special delivery unit, we have very high rates of human milk at discharge. And this is really important because this is considered to be a quality metric in healthcare for vulnerable infants. So that gives you just a little historical background. And what we're going to focus on now is what we can do for both adolescents and homeless families in terms of improving human milk and breastfeeding access, support, care, and evidence. So we know that presently in the United States and around the world, the current practice paradigm is not really working to ensure that all families are meeting their personal breastfeeding goals. In the United States, breastfeeding rates are suboptimal, and there are tremendous geographic and racial and ethnic and income disparities. We look at the differences between white women and African American or Black women, and we have almost a 20% difference in initiation. And when we look at income, we also know that that is a significant negative influence for breastfeeding initiation if someone is from a low resource setting. And when you think about homeless families and adolescent families, these are mothers who, or families who may be at the lowest poverty ratio in the United States. We also know that WIC can either positively or and sometimes negatively affect breastfeeding rates. So especially in this time of COVID and the pandemic, we really have to think of both our adolescent mothers and our homeless families in terms of really promoting and protecting human milk and breastfeeding. Because during this pandemic, families may not have resources to purchase formula, or they might not even be able to access it on the store shelves. So it's really critical that we start with ensuring all families are making informed feeding choices prior to delivery. And so this is actually the first step of my model. And we know that many people do not initiate breastfeeding due to culture, a lack of family support, a lack of education or exposure to breastfeeding. So we have a particular obligation as healthcare providers to make sure families are making informed feeding decisions, including our adolescent families and our homeless families. So when we think about return to school, I want you to reflect on your practice and the state or the county that you live in. How many of your schools have policies that protect the rights of breastfeeding students? How many of your schools have on-site daycare so that the mother or the parent can breastfeed on-site? What about protection of the parent to express milk? So Philadelphia Public Schools expanded their policy for pregnant, parenting, and married students to place a significant emphasis on chest or breastfeeding and pumping accommodations. So they have had a policy in place for pregnant, parenting, and married students, but what the new policy has done has really underscored the importance of human milk. In January of 2019, we were able to obtain Symphony pumps on site for the public schools. And the ELECT program, which is a program for pregnant and parenting teens, provides the family with pump kits, storage bags, water bottles, and other supplies. So when there is a pregnant or parenting teen planning to return to school, the ELECT counselor is notified and the breast pump is deployed right to the school. So with our students at the University of Pennsylvania, we provide education to the pregnant and parenting teens in the Philadelphia School District. And I have been working with this program for well over a decade. And so this semester was very interesting because of the COVID pandemic. And our students had to go to virtual learning. And that meant the Philadelphia Public Schools. And so we were really concerned because the students had planned, Julia Ann to work with 2 high schools and Greta working with a different 2 high schools. All of that kind of got thrown away because of the pandemic. And so we had to change to an online platform. And so we were very nervous that we would not have any participation, in particular because in Philadelphia, the students didn't get their Chromebooks until about the week before the presentations occurred. But despite the pandemic, we reached over 30 people. So this tells you that adolescent families really do want to learn about human milk and breastfeeding. We also want to consider universities. And in this research study done with a student from the University of Pennsylvania and some colleagues at Pittsburgh, we found that very few universities had official policies for lactating students and/or had lactation spaces mentioned in their student handbook. We then further this research with a partnership between the Society for College and University Planning and an MPH student and an architect, and looked at what's happening on college campuses today. And we still see that there is a lack of consistent services for students at the university or college level. What about breastfeeding and homeless families? How do you believe that COVID-19 has impacted families? Do you know anyone who has experienced unemployment due to COVID-19? And do you know families that have faced homelessness? These are all real live questions that are affecting all of us today during this pandemic. So the Homeless Health Initiative at Children's Hospital of Philadelphia provides free health and health-related services to families living in local emergency housing shelters, and it's run by volunteers from our organization. With the Homeless Health Initiative, students in Nursing 361 have been providing education at homeless shelters. In addition, the Homeless Health Initiative at CHOP was able to procure hospital-grade Symphony pumps for several of our homeless shelters in Philadelphia. So in addition to the homeless shelter having a hospital-grade pump, the Homeless Health Initiative is also providing the parent with a free pumping kit. Now, when we think about homeless families in particular, homeless families are absolutely at risk for toxic stress. And if you're not familiar with the concept of toxic stress affects us for the rest of our life and can lead to long-term health implications and health outcomes. So human milk and breastfeeding are critical interventions to mitigate toxic stress. So when we think about the buffering effect of breastfeeding, okay, breastfeeding is something that we really want to stress for our families who are at high risk. So if you think about socioeconomic impacts, there are decreased financial stressors. Even if you're enrolled in WIC, that doesn't provide all the formula that a family needs. When you think about skin-to-skin contact and bonding and attachment, and then when we think about the neuroprotective and anti-inflammatory and antioxidant properties of human milk has the ability to transform not only that infant's life, but that entire family's life. So we really want to think about that ability to use human milk and breastfeeding as mitigating factors. Thank you so much for my time. My email is listed, and if you have any questions or would like any of the references I provided, you can feel free to contact me. I am also currently accepting mentees. Thank you.
Hi everyone, my name is Nina Juntereal and I'm a first year PhD student at the University of Pennsylvania School of Nursing. I'm a PhD student in the Hillman Scholars Program in Nursing Innovation. It's a competitive BSN to PhD program which strives to create the next generation of nurse scientists. Thank you everyone for being here today. This is part 2 of our webinar, Optimizing Lactation Care for Diverse Populations. And I'll be discussing specifically on the lactation care for same-sex mothers. So please note, privacy and confidentiality of the participants is of the utmost importance. So all moms who self-selected their own pseudonyms and were aware that their stories would be shared publicly for research and educational purposes. And we have no disclosures related to this presentations. So the objective of this presentation is to discuss the health needs and concerns of breastfeeding same-sex mothers within a heteronormative healthcare system. So a little background. So Dr. Spatz mentioned her course on Nursing 361. So just reiterating that my research journey began as an undergraduate student in this course. So at the University of Pennsylvania School of Nursing, all undergraduates are required as part of the curriculum to enroll in a case study seminar. So these seminars provide an in-depth focus on a specific topic. So with a strong interest in maternal child health and nutrition, I enrolled into Dr. Spatz's class, Nursing 361, the case series seminar on breastfeeding human lactation during the spring semester of 2018. So in this course, students get exposure on lactation content, both didactically and clinically, and actively engage with the content to develop a final project. So during this course, one lecture was dedicated to the culture of breastfeeding. Dr. Spatz presented on the lactation care and breastfeeding behaviors of various family structures and the health disparities of breastfeeding initiation and duration among minority populations. I asked a lot of questions since I had a keen interest on the lactation of non-traditional families, particularly same-sex female parents. Because of all my questions, Dr. Spatz encouraged me to conduct a literature review and transform my questions into a research project. So these were my questions that were in my head during the time. Who is advocating for these families? Do professional organizations cite support on lactation for sexual and gender minority populations? As I was reviewing the literature, I noticed a lack of lactation advocacy in the policy statements of professional organizations and leaders with regard to the LGBTQIA2S+ community. For reference, this acronym, as defined by the Sexual and Gender Minority Research Office of the NIH, stands for lesbian, gay, bisexual, transgender, queer and/or questioning, intersex, asexual, two-spirit, and the countless affirmative ways in which people choose to self-identify. The 2011 United States Surgeon General's call to action to support breastfeeding does not mention the needs for non-heteronormative families. Also, the American Academy of Pediatrics and the American Academy of Family Physicians support induced lactation for adoptive family in their statements, but fail to expand this practice for LGBTQ families. Only La Leche League acknowledges and supports lactation care for same-sex and LGBTQ+ families. They have updated their position statement to include transgender and non-binary parents who choose to breastfeed or chest feed their infants. The practice of induced lactation serves as an opportunity for non-gestational parents to lactate and participate in breastfeeding. The majority of research on induced lactation is centered on adopted families. As defined, induced lactation is the process of stimulating lactogenesis in the physiological absence of pregnancy. Mothers whose induced lactation typically cannot provide enough milk to exclusively breastfeed, but choose to undergo the process because they want to share in the maternal-infant bonding experience of breastfeeding. Protocols available on induced lactation vary, and none are officially endorsed by the American Academy of Pediatrics, the American Academy of Family Physicians, or the American College of Obstetrics and Gynecology. The process of induced lactation requires a balance of various methods, including non-pharmacological, pharmacological, and hormonal in combination to stimulate milk. So with Dr. Spatz's guidance, I have published 2 studies on the lactation experiences of coupled sexual minority women, specifically same-sex mothers. The study on the left is a case series manuscript in the American Journal of Maternal Child Nursing. This manuscript was developed as my final project during my time as a student in Nursing 361. The clinical aspect of this project of this class afforded me the opportunity to attend breastfeeding classes at the Children's Hospital of Philadelphia and interact with mothers who were interested in sharing their lactation experiences with me. This manuscript provides clinical recommendations for nurses and other healthcare providers to support the lactation outcomes of these families. This project informed me in how to develop a formal research study to further understand the lactation experience of same-sex mothers in the context and perspective of the gestational mother. The Office of Nursing Research sent out a call for proposals in 2018, and with Diane's guidance, I wrote and submitted a grant proposal and an IRB application. I successfully obtained funding and received approval from the IRB to conduct the study. The study is shown on the right and will focus the rest of my presentation. Breastfeeding experiences of same-sex mothers, and it's a mixed method study. The quantitative arm involved an online survey to characterize the demographic of same-sex mothers and if their healthcare provider included discussions on induced lactation during prenatal care. Our findings demonstrated that mothers have strong intentions to supply human milk. Compared to the national average of mothers, the breastfeeding rates of our sample is much higher. And only 21% of our sample reported that a healthcare professional spoke to them about induced lactation for the non-birth mother. The qualitative arm explores and gains an in-depth understanding of the lactation and breastfeeding experiences of our mothers. Based on the interviews, we identified 5 key themes. The following slides contain illustrative quotes that represent the feelings and lactation experiences of these mothers. The first theme is committed to year. This theme reflects a similar finding in the survey results. Mothers were dedicated and wanted to breastfeed.
We plan to breastfeed and co-nurse at least through the first year. That was our goal.
The second theme is deciding how to do it. Coupled sexual minority women had thoughtful plans to start a family but needed to navigate the process, which consisted of multiple paths to determine which approach best suits them.
As 2 women, we had to decide whether we were going to use a sperm donor or a known donor. Fertility clinic as opposed to in-home insemination.
The third theme is sources of information. Mothers took initiative in educating themselves on breastfeeding, whether it was seeking general information on breastfeeding or information on induced lactation and co-nursing or co-lactation. The majority of providers had limited information on breastfeeding. For induced lactation, mothers sought information from outside sources, such as from friends, from books, or from online forums, and were the ones controlling their experiences since providers had limited knowledge on the process.
They didn't talk at all about it. I had the intention that we were going to co-nurse. That was something they didn't bring up. I asserted our plan.
I was actually the one that brought that up. I was doing research.
The mothers also felt that they missed out on a critical opportunity because they had not heard of or access to this information in prenatal care.
I wish we could have known, because then we would have really sat down and said, is this something we really want to do? She really would have considered it. It would change the landscape in terms of her work, how much time she got off, and all that. It definitely would have been nice to know a lot earlier.
The fourth theme is the involvement of the partner. Partner can also contribute to the maternal-infant bonding connection of breastfeeding by participating in skin-to-skin, bottle feeding, or through the experience of induced lactation and co-nursing itself.
She was the one who got to hold him for the first 20 to 30 minutes of his life. Just because I'm the birth mother does not at all make me more of a mom than my wife.
Mothers believe the experience of co-nursing has a positive impact on their family. These mothers understand that induced lactation and co-nursing is a process, but they are willing to proceed because they are dedicated to exclusively providing human milk. Through the process, they realized that the experience also strengthened their connection as a family.
This co-nursing is a really rare thing, and I am personally really grateful that my family has done it. You know, at times it has been challenging to manage, but on the whole, it has been markedly beneficial for the both of us and the baby in terms of all our mental, physical, emotional health, and well-being and bonding. And so I will encourage anyone who is curious about it to do their research. Reach out to communities that have experience with it and see if it's a fit for you. I understand that it's not a fit for everyone, but I think it can make a significant difference, and it's a real thing.
With regard to the current healthcare system, mothers felt that a heteronormative paradigm is in place. Resources available on family planning and lactation remain hetero and cis-normative. There is an explicit maternal focus with limited discussion of other types of families and parents. Due to the binary nature of healthcare, mothers often feel like outsiders or invisible when all they want is a sense of normalcy.
There's a difference between accepting and actually being competent about the unique care needs of families like ours. In the case of, we are a two-mom family and we are both nursing.
This is the fifth theme, is the need for inclusive and educated healthcare providers. These families believe that there's a need for more awareness and access to information on induced lactation. They cite that referrals to knowledgeable lactation consultants would be more appropriate than no information at all.
There is a general lack of understanding and acceptance of anything that's different than what they're used to. I wish people would just read a few articles, try to educate themselves, and remember that we are also human beings. I had a couple of cases where someone said to me, "Oh, it's so interesting to meet a family like yours. I've learned so much." I would like them to come and see us as an individual family, the way they might see any other family.
The Academy of Breastfeeding Medicine published a clinical protocol on lactation care for LGBTQ+ patients. This protocol serves as a guideline and is not exclusive or a standard form of treatment or medical care. The protocol discusses the importance of language and definitions of gender-affirming terminology. The authors describe specific actions to create a more respectful environment in healthcare settings, the effect of transition-related healthcare in pregnancy and breast, chest feeding, and birth. There's also an example of a co-lactation feeding plan outlined at the end of the article. I would encourage those interested in learning and wanting to support affirmative lactation care for these folks to read the protocol to understand the options available and the considerations for this community related to lactation. With regard to clinical practice, the Children's Hospital of Philadelphia serves as an exemplar in providing gender-affirming lactation care. Their hospital-wide breastfeeding committee recently approved an update of their milk expression logbook, updating its terminology to be inclusive of diverse families. Before I close, I just want to acknowledge those who have supported and continue to support my research endeavors and growth as a PhD student and future nurse scientist. To Dr. Spatz, thank you for being an amazing mentor. To the Office of Nursing Research, this research was funded by the University of Pennsylvania School of Nursing student grant. And to my Nursing 535 classmates, thank you for your creativity with the design of this presentation. And to the Hillman Scholars community, thank you for serving as a home for my academic and professional growth. So below is my contact info and Twitter username. Please feel free to contact me with questions, comments, or for resource sharing. Thank you very much, everyone.